So we're going to talk a little bit about the evaluation as well as the management of mid-substance Achilles tendinopathy. So the first thing you want to do often is just examine the patient in the prone position. It's the easiest way to get to the Achilles. Um, you want to inspect to see if there's any areas of swelling or thickening of the tendon. You can differentiate between insertional Achilles tendinopathy and mid-substance tendinopathy based on where they hurt. Insertion is going to be right at the distal part of the Achilles, whereas the mid-substance tendinopathy is going to be 2 to 6 centimeters above the attachment of the Achilles tendon, which is the focus of this exam and this article. One described test for Achilles tendinopathy is the painful arc sign. This involves palpating the area of pain in the tendon swelling, and as the foot's taken through a range of motion from plantar flexion into dorsiflexion, that painful area moves with the tendon. This can help differentiate from things like peritendinitis. Another test that's fairly specific but not all that sensitive for Achilles tendinopathy is the Royal London Hospital test. This involves palpating the area of pain, and then the foot's taken into a extended or dorsiflex position with putting tension on the tendon, and that actually alleviates the pain. I do want to talk a little bit about diagnosis of an acute Achilles tendon rupture, just to be able to differentiate this. You can palpate a defect sometimes in the Achilles tendon itself. A common test is the Thompson sign or calf squeeze sign. This involves squeezing the calf and watching the foot go into a plantar flex position. This indicates that the tendon is intact, and so that would be a negative test there. A positive test involves the foot not moving into this position and remaining in a dorsiflex position. You could also examine the foot just to see the resting passive position of the foot, dorsiflexion versus plantar flexion, and compare it to the other side. It's important not to miss an acute Achilles tendon rupture, although it is a little bit beyond the scope of this article. Next, we're going to talk about treatment for Achilles tendinopathy with eccentric training. This involves the negative portion of the work. This was described by Alfredson back in 1998 and still remains a common part of treatment for this. You'll have the patient up on a step and really going to focus on the descending portion of the exercise. So this is focusing on her right side currently. So she's going down very slowly with almost all of her weight on the right side and then back up with either both feet or most of the weight on the left side, the non-injured side. This will be performed 15 repetitions, 3 sets, twice a day, as it was originally described, every day. As they become less painful, you can add weight in the form of putting weights in a backpack. This exercise is done both with the knees extended as well as with the knees bent. And you'll see her do this. This is a little bit more difficult with the knees bent, but the exercise remains the same. Initially, if the patient's very painful, you may have them use both feet more for the descending or eccentric part of the exercise, or you can have them hold onto a railing or countertop. One other note is that for insertional Achilles tendinopathy, or if the patient's extremely painful in mid-substance, you may have them do this on flat ground. That may decrease some of the strain on the tendon, but still get the negative or eccentric work.